So I would like to start then with Dr. Hashim. He will give the first lecture, maybe a few words. Dr. Ahmed Morad Hashim, excuse me if I do not pronounce that correctly.
No, correctly is excellent.
You are the professor of internal medicine and Hepato-Gastroenterology at the Cairo University in Egypt.
Yeah.
A member of the editorial board of the Egyptian Journal of International Medicine.
Yeah,
Is that
internal
correct?
medicine in Cairo, yes.
Is there anything you would like to add to that?
Yeah, that's okay.
That's okay. So please, if you bring your presentation online, then I think we're good to go.
Okay, we will.
Thank you so much.
Thank you. Bismillah ar-Rahman ar-Rahim. It's a great honor and a pleasure to be with you in a first International Gastroenterology educational series with you, Ahmed Morad Hashim, Professor of Gastroenterology, Internal Medicine, Cairo University. Today, we will answer a very important question. What is this? IBD and IBS are 1, 2, or 3 diseases? We will answer this question with each other. For many decades, our topic today is hazy, unclear, unarranged. So today we'll clarify it at the beginning, rearrange it, and then present it as a clear, arranged topic. Let us start. For many decades, many rumors, till now, many rumors ask and tell that there is a relation between IBD and IBS. Today, we come to shut up the mouths of all rumors. We come today to find a relation between IBD and IBS. But before we start, we want to ask a little question. What are the possible relations between IBS and IBD? Most of our physicians said that they are 2 separate entities, not related to each other at all. This is a disease and this is another disease. Another group of physicians said that there is just a coincidence. IBS run in its way, IBD run in its way, and they meet to each other sometimes in some patients. Some said that, no, they are 2 separate diseases, but with some overlap between both of them. And the other said that IBD may be an advanced IBS condition. So it is just part of IBS as a great spectrum. The other said that maybe IBS and IBD are part of another larger disease, which is a 3rd disease. So if we collect the possibility, the first possibility is IBS and IBD are 2 separate diseases, not related to each other at all. It may be there is some coincidence between both of them. Third, there is maybe some overlap. The 4th possibility that IBD is an advanced IBS condition. And the last, there is another disease. We don't know about it. And it contains both of them. The physician who said that IBD and the IBS are 2 separate entities, they are strong because many evidence, they are completely different. Why they are completely different? They said that They represent a separate entity with no any intrinsic relationship. IBD is described as a heterogeneous group of disorder, various forms of mucosal or transmural intestinal inflammation, while in IBS, just functional bowel disorder without any detectable structure abnormality or pathology. BR bleeding in IBD, not part of IBS at all. Red flags manifest like weight loss, anemia, fever, elevated ESR, just appear in IBD, not in IBS. Extraintestinal manifestation not appear in IBD, in IBS. Nocturnal bowel symptoms not appear in IBS. So they are completely separate. While IBS is just functional, like associated with headache, rheumatological pain, genitourinary manifestation, night frequency, fibromyalgia, sexual dysfunction, sleep disorder. All of these are functional disorder. It's not organic. So who said that they are two separate entities are strong evidence, and they stay strong. They are completely different. So we ask why you present this lecture today. So we go back to the starting point. Why did we ask this question from the start? Why IBS and IBD are related entity or not? Why you ask this question? I ask this question because our observation. We observe, and I think most of you observe that also, that IBS many times in many patients is a prodromal of IBD, and IBS also may be like symptoms in IBD in a remission, when IBD in a remission or even in activity, some manifestation of IBS are present. Okay, we come to the important issue. How can you prove or prove that they are either related or not related to each other? We will put a possibility. If we found a relation as regard the etiology, the pathogenesis, the clinical picture, the investigation, and the treatment, we have a relation. So let us begin with etiology and the pathogenesis. The etiology of both IBD and IBS remain unclear. You agree with me that. But all these are common in both, like dysregulation of the enteric nervous system. Both of them have this possibility. Altered microbiome. We will speak about microbiome today so much. Altered mucosal permeability. Yes, this is a possibility for both IBD and IBS. Grade of mucosal inflammation. In IBD, it's clear that it's an inflammatory condition. Ulceration, hyperemia, and many inflammation. And low, IBD, IBS is an inflammatory condition? Question mark. We will see that later on. The other possibility are that they are share in brain-gut axis abnormality, share in gut motility alteration, share in bile salt malabsorption, and life stresses. Both have life stresses, and the research puts this as an important entity. So there is some overlap between pathogenesis of both two conditions. If we speak about dysbiosis, we'll speak about dysbiosis much today. Microbiome disturbance is the key link between IBD and IBS. All research and all researchers put that in their mind during evaluation of the pathogenesis of both IBD and IBS. Even in the way of treatment of dysbiosis, they put fecal transplantation, helminthic therapy, pre and pro and antibiotics in both IBS and IBD. Very good. Albert Einstein said that the most important question a person can ask is the universe a friendly place? But today we ask another important question. Is there any role of inflammation in IBS? If there is any role of inflammation in IBS, we will solve a big problem. And it is a cornerstone in this lecture today. So we will investigate that. it was found that IBS has a higher level of pro-inflammatory cytokines in the peripheral blood, like interleukin 6, interleukin 8. There is increased release of tumor necrosis factor, interleukin 1 beta, and interleukin 6 in mononuclear cells. And in IBS also, there is a higher level of cell infiltration of the intestinal mucosa. A study done to evaluate the histamine and the tryptase level in both normal in compared to the IBS patient, they found that a higher level of histamine and tryptase in a IBS patient. Electron microscopy study found that there is increased mast cell number in IBS, especially in the terminal ileum and cecum. There is increased mastocyte in the colon near the nerve ending, increased CD3 and CD25 in the intraepithelial lymphocyte in the colon. So it is exciting enough that they found a very important and exciting issue, that this level is correlate with the intensity of intestinal symptoms. The more the CD3, CD25, mastocyte in nerve ending, the more the abdominal pain and the more the psychological symptoms like depression and fatigue. It's very exciting. So they postulate that if a patient is subjected to previous gastroenteritis, genetic factor, food allergies, altered microbe flora, they will cause a activation of extrinsic primary afferent neuron pathway that evoked visceral hypersensitivity, which causes abdominal pain. And if this low-grade inflammation affect the intrinsic primary afferent neuron, it will alter intestinal motility, which cause altered bowel habits. So both of IBD and IBS have the same postulate of doing their symptoms. So IBS has an immune system activity, but with milder intensity. But the milder intensity maybe tomorrow is moderate, and after tomorrow is severe intensity. So it may be lead to gut inflammation on the continuum, which is lead to IBD. So no one can say that IBS is only functional. It's not only functional. It's not only functional. It is not only functional. So we must change our mind to change our life. So no longer useful to think that it's only functional. It's only motor disorder, motility disorder. But the mechanism is not fully understood till now. So I put the postulate that IBS, when the patient subjected to previous gastroenteritis, genetic factor, allergy, altered microflora, it affects mucosal barrier and maybe the defect in a mucosal barrier. So lead to passage of luminal antigen inside, activation of the submucosal immune system response. And this is not proved, the last step, that it may cause IBD, which is the manifestation of IBD, that severe inflammation of the mucosa of colon or intestine generally. This is about the pathogenesis and the etiology. What about the clinical picture? Rome criteria, especially the last one, said that to diagnose IBS, you must have a recurrent abdominal pain 1 day every week for 3 months, with 2 of the following relation to defecation associated with change stool frequency and change appearance of stool. If we go to the IBD and take the typical symptoms of IBD, we found that 4 over 6 classic cornerstone symptoms are shared between IBD and IBS: abdominal pain, diarrhea, fatigue, nausea. All of that occur in both IBD and IBS. So there is overlap between IBS and IBD as a clinical picture. Both have abdominal pain associated with altered bowel habits. So both IBD and IBS include altered bowel habit, irregular habits, bowel urgency, mucus, and maybe in some cases constipation. The pain of both IBD and IBS present as a cramping pain, bloating, distension. Both IBD and IBS is a chronic relapsing on and off, on and off. Both IBD and IBS symptoms has a clinical relapse, multifactorial, incompletely understood. All of these are shared between both IBD and IBS. So we found that also in a prodroma period of IBD, the patient present sometimes with abdominal pain, altered bowel habit, change form of stool. In IBD, in a prodroma, before the overt manifestation. So we think this manifestation, if we think about it, it is the classic symptoms of IBS. This would suggest that many IBD cases started as IBS symptoms. So many research is done about that. Retrospective and population-based study indicates the presence of IBS type symptoms up to 20 years. Yes, 20 years before the diagnosis of IBD. And this made the possibility of it may be a prodromal of IBD. Another study found that the patient with IBS is 8.6 a higher risk to be IBD other than normal population. Very important. If the IBD was 8.6-fold higher in patients with IBS than normal population. Another study, large population-based study, shows that there is more than 10-fold increase the risk of IBD among those patients with IBS. Very interesting. And another study found that the prodromal period of IBD as IBS in Crohn's, it is 7.7 years as IBS symptoms, and in ulcerative colitis, up to 1.2 years as IBS symptoms. On the other side, and on the other hand, IBS symptoms in the remission of IBD, the patient with IBD going into remission, they found that 1 in each 3 patients with IBD continue as IBS symptoms. Every 3 patients with IBD going to remission, 1 patient remain with IBS symptoms. The presence of IBS-like symptoms were found in 60% of patients with Crohn's disease in remission, and about 40% in patients with ulcerative colitis in remission. Another study, another meta-analysis study with 13 studies, they found that 36% of patients with ulcerative colitis in remission have IBS symptoms, and 46% of Crohn's in remission have IBS symptoms. What about the investigation? Lab investigation in IBS and IBD. IBS is nothing, just to be sure that there is no red flags. In IBS, in IBD only, maybe the fecal calprotectin is considered as a lab investigation, the official one or the commercial one. The level below 50 milligram per gram is an indicator of no inflammation, and we think that the patient going to IBS more. And if it's above 200, it will indicate that there is an inflammation, active inflammation, and it goes with IBD. So what about the level in between, the gray zone between 50 and 200? Maybe low level of IBD or high level of IBS, or take care, pre-IBD IBS. So, and IBD in remission was associated with, which associated with IBS has a higher level than the patient of IBD without IBS manifestation. And sometimes the patient with IBS has a mild elevation of calprotectin as in post-infectious IBS. All these give a clue that there is some relation. It's like a continuum to each other. So calprotectin below 50, it is no inflammation, slightly IBS. Above 200, it's inflammatory condition, likely IBD. And in between, it's the gray zone. So many biomarker like C-reactive protein, lactoferrin, tumor necrosing factor, nitric oxide, and many also has a gray zone, like in between. It is not above to be IBD and not below to be IBS. It is the area in between. What about treatment? If they share the treatment, maybe share the disease. It was found that antidepressant therapy in IBS, which is the cornerstone in IBS now, help also to reduce abdominal pain and diarrhea in IBD patients. Also, in patients with IBS diarrhea, there is a statistically significant improvement in abdominal pain and diarrhea after 12 weeks of methylamine, which is also a cornerstone of treatment of IBD. And as we said before, dysbiosis, the main front of treatment in both condition, IBD and IBS, on fecal transplantation, helminthic therapy, bovine colostrum, pre-pro antibiotics, all of them are the same in both IBD and IBS. Dietary therapy. Dietary therapy, it was found that both therapies of IBS and IBD as regard the dietary therapy is the same. We advise to low in food map show benefit in both patients with IBD and IBS. And lastly, now we will answer our question. IBD and IBS, 1, 2, or 3 diseases. We'll answer it with complete confidence. The answer is, I don't know. Yes, I don't know. Because the paradigm may be start by post-inflammatory IBS, continue as IBS, activated as subclinical IBD, activated to active IBD, or maybe another new entity, new disease, which is inflammatory IBS, which is the main items today we think about it, inflammatory IBS. So, till now, IBS and IBD are two separate diseases, but can be considered as the same category with different presentation. Further research, that is the aim of our lecture. We need further research in this. We start here in Egypt, some researches about that. There is a relation or not between IBD and IBS, because if we found that, we will have a very good preventive strategy for IBS and the consequence of IBD. And thank you so much.
Goodbye, 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 friends. Goodbye, goodbye.
Wonderful. Thank you so much, Dr. Hashim. This was
Thank you so much.
a wonderful presentation. And we already have here a couple of questions now to follow up. Firstly, I love the fact as an organizer, of course, that you also stick to the time, but that's maybe my Austrian gene here coming through.
Egyptian gene.
No, very well. Thank you so much.
Thank you.
Dr. Hashim, I have a question here. How do you see the role of the microbiota in autism? This question.
This question for me or for the next? I think it is not related to our lecture today.
It is not. No. So I was. I think we passed this on. Let me go to another question.
If you want this, but it will be the lecture of Dr. Francesco, I think. Yes.
Thank you so much for helping me in this one.
Yeah. Don't worry.
Let me ask you this: is there any proven relation between IBD, IBS, and microscopic colitis?
Yeah. For many years, they suggest that the microscopic colitis is midway between IBS and IBD. But microscopic colitis as an entity is related to inflammatory bowel disease. It is a subtype of inflammatory bowel disease. If it related to IBS, it will help us. It will solve our problem today. Microscopic colitis, if you know that it is just a patient has a diarrhea, chronic diarrhea, mostly in old age, there is many types of microscopic lights, up to 9 types. The most important is lymphocytic and collagenous. The patient during endoscopy is clear, it's normal endoscopy and do not appear except by pathology, by biopsy. Till now, there is no relation proved between IBS and microscopic colitis. If it is proven, it will be a very good step in improving the relation between IBS and IBD.
Okay.
Yes.
I have a question here from Hani Osman, a consultant of surgery. Why you didn't add antihistaminic treatment to the management of IBD and IBS, as you described that there is an increase in the histamine in both cases?
Question. Very good question. Very good question. All this investigation and studies what I already presented is just a study as a minimal level. It is not a higher level to be treated to solve a problem. It is just a marker which is causing over-infection, over-affection, of over-inflammation that seem to be treating the condition if it's treated. So I don't know if there is any study about giving antihistaminic for that or not, but the study which I present is just mild elevation, but statistically significant.
Okay.
Yes.
Gazer Al-Azab is asking, can we try mesalamine in patients with IBS, patients with IBS with high calprotectin?
Calprotectin, yes.
Protectin, sorry.
I present a study also about that. They give 500 milligram of mesalamine for about 14 weeks for patient with IBS with diarrhea. It's tried with diarrhea only, as you know. And it gave a significant improved, but it's not allowed to use that except in experimental study or in research only, not in a market, as IBS and IBD is not diagnosed except by the criteria which is we must follow.
Okay.
Yes.
Asma Maher is asking, can acupuncture relieve IBS symptoms in your opinion?
Yeah, one of the method of treatment of IBS, you know that many theories that is a gut-brain axis, and according to that, acupuncture or homotherapy or something like that, it can help to some extent. But mainly it's antidepressant therapy and spasmolytic therapy is the cornerstone of IBS now.
Okay. This is a question from Hala Al-Zayed asking, does zinc deficiency have any relation to IBS as it's related to IBD?
Yeah, some study about that, but no proof till now.
Okay. So Antoine Shalida is asking if there's a difference between the two diseases in the risk of malignancy. How
Yes,
can you explain that?
Sure. Any inflammation, any chronic inflammation can be a pre-malignant condition. So it's a completely different between both, because it is if we speak about the IBD and the IBS, if we put both of them in a spectrum, IBS is the beginning of the spectrum and IBD is the end of the spectrum. So we afraid from malignancy in IBD after 8 years. After 8 years of IBD. So it is at the end of the spectrum. So it's not related to IBS by any mean.
Okay. So Mohammed Sofar is asking, if there's an inflammation in IBS, how can it be released by antispasmodics only?
It's a symptomatic treatment, not a curative treatment. If it is the inflammation, and we prove that it's inflammation, anti-inflammatory is the curative treatment, but till now it's not done. we give spasmolytic only as a symptomatic treatment, just to relieve the condition at the moment, but not a curative treatment.
Okay. Here's a question from Mohammed also. Did you consider how would you treat the side effects of antidepressants if antidepressants are used in the treatment of IBS, psychological ones and physically also maybe in the gut?
Yeah. Look, it's a general question. Any drug, we give it at the lowest and the shortest period, at the lowest dose and the shortest period of time, give the effect. All drug like that, if it's according to cost and benefit. So you must know the side effect and accept some side effect to gain the benefit of a drug. It is just general, but it's a general question. We cannot answer how can we avoid it. It can be done at any time with any person.
Here's a question from Yosef Kamal asking if there's an iron deficiency, there's a relationship between iron deficiency and IBS and or IBD.
Yes, iron deficiency in IBS, it is one of the red flags. If you found an iron deficiency with patient with IBS, you must search for another disease, malignancy, IBD, ulceration, or any masses. So iron deficiency cannot be accepted to be in patient with IBD only. You must search for a dangerous disease like IBD or malignancy.
Okay. Dr. Fayez Hassona is asking whether rifaximin in the treatment of IBS has a role also in the treatment of IBD.
In IBD, yes, it has a role, yes, but in IBS, no.
Okay. How do you see the role of Ebastine in post-infectious IBS?
I don't know.
I don't know. It was also an anonymous question, so you get an anonymous answer. How do you see the treatment of antidepressants in IBS and or IBD?
How?
How relevant do you see
the use of
antidepressants?
Very important. Very important.
And do you see a difference between IBS and IBD there in the appliance?
As I said,
application, sorry, of those drugs.
As I said, that in IBS, antidepressant drug is one of the cornerstone in treatment of IBS. That's sure. In IBD, we don't know if it's internal or external depression. It is intrinsic or extrinsic depression. Either it's the patient has depression due to IBD or the patient has association with depression. But antidepressant in IBD, it will help a patient a lot, even in symptoms. If his symptoms like diarrhea, it was found that it improves the diarrhea if the patient take antidepressant in IBD.
Okay. So thank you so much, Dr. Hashim. A lot of questions answered, and I'm very happy that we got through a lot of them. Apologies to all of those that asked and could not. Thank you so much once again here.
Thank you so much, and thank you to all the attendees. They reach now up to 2,000, about 2,000, and I said from here, thank you so much. Bye.
Thank you so much, Dr. Hashim.